Ahora nos toca presentar.
Okay, Dr. Stanford. Now I will introduce the next speaker. That is very interesting. The other side of the coin. We have been saying this day that the natural methods of fertility awareness are methods that can help us. It's also a diagnostic technique that helps the physicians to be able to see how the reproductive situation is and suspect some pathology. We who have dedicated to this, we have realized that it really works as a tool and also as a possibility of monitoring these that we tell the patients about. One of the persons who have most advanced in this aspect is Dr. Phil Boyle, our next presenter. He is founder and director of the Neofertility Clinic in Dublin, in Ireland, and that belongs to a very interesting association, the International Institute of Reproductive Medicine, that brings together physicians and not physicians, also, but scientists who approach infertility from a restorative perspective, trying to reach the diagnosis in the best possible way and not doing any bypass of any physiological procedure, but try to restore the physiology that for one reason or another is not functioning adequately. The restorative medicine that Phil Boyle is a great expert in. The results of patients with infertility problems and how they have been able to get pregnant with this approach that he will be talking to us about. He has over 4,000 successful pregnancies. It's an honor to have him with us. We have to take advantage of it and listen to his presentation and then questions and comments. It's very interesting to have that approach that he is presenting to us. Dr. Phil Boyle, welcome.
Hello, my name is Dr. Phil Boyle, and I'm happy to give you a presentation comparing our live birth data outcomes with restorative reproduction through our practice with neofertility compared to the official statistics that are reported for in vitro fertilization. My conflicts of interest: currently I'm the president of the International Institute for Restorative Reproductive Medicine. No financial connection there. It's just, well, I have an interest in restorative reproductive medicine and promoting it. And I'm the co-owner and developer of the fertility app at chartneo.com. I would like to give acknowledgement and recognition to Dr. Thomas Hilders of Omaha, Nebraska, the founder of Napper Technology, and grateful appreciation for his teaching and mentorship. Who was the biggest influence in my life to encourage me to look at restorative reproductive medicine. What is restorative reproductive medicine? Well, it is any medical or surgical treatment that restores optimum reproductive function. The website for restorative reproductive medicine is listed iirrm.org. And the key thing for restorative reproductive medicine is we work with a fertility chart. And the fertility chart is our roadmap to guide everything we do. With Napper Technology, a key thing for that is you work with the Creighton model chart. With generic restorative reproduction, we work with a multitude of charts. I work with the Neofertility chart. We can work with the Billings chart or symptothermal as well. This guides our hormone assessment, which is very precise and particular. It guides our multifactorial medical treatments. We time ultrasound scans around the chart. We complete male factor assessment and treatment. We complement our approach with good surgery, and psychological and emotional support is paramount. We put all of this together and we have this multifaceted approach to assessing and managing the cycle. This is what our fertility app records at chartneo.com, where we document the bleeding pattern, the mucus flow, the day of presumed ovulation. We record a temperature shift, and we also can use a clear blue ovarian monitor to look at high days and peak days, and they all correlate very nicely together. We document the days of intercourse, we document the medications that are taken, any negative symptoms like period pain or low mood or fatigue. We get all of this on our app. So I quite like our app because it gives me everything at once, and I can get quick, easy access to see, do we have the balanced cycle we're looking for? A key difference with restorative reproduction is we continue for 12 balanced cycles. So everybody agrees that it is normal to take a year to get pregnant, and you don't have a fertility problem unless you've been trying for a whole year. Researchers in the UK tell us, in fact, if you're under 35, it could be normal to take 2 years to get pregnant before you'd even consider investigations or treatment for impaired fertility. So a year of balanced cycles is very reasonable. And a key thing with restorative reproduction is if you're not getting pregnant, there has to be a reason. If we find that and fix that, then a couple's loving embrace at the appropriate time over 12 cycles, we'd expect fertilization should occur. The contrast with in vitro fertilization is it's a technological, scientific process that is removed from the loving embrace of the couple. And it becomes a more cold, clinical, detached production process rather than a baby being a fruit of a couple's love. So the processes are quite different from that philosophical point of view. And I want to compare it then with a real example of two couples who have come to our practice recently with a very similar history. They're both in their early 40s. They've both been pregnant 3 times, had 1 successful pregnancy followed by 2 miscarriages. So they also, as it turned out, one of their miscarriages was shown to have a chromosomal abnormality. And they presented to their doctor before coming to us and was told, "Doctor, what are my options? What can I do? I'm in my early 40s and I don't seem to have a problem getting pregnant, but I've had 2 miscarriages and 1 was a chromosomal problem." Well, the IVF clinic, in both cases, to the couples I have seen, they say, well, for nearly €10,000, we can provide ovarian stimulation and egg retrieval with an IVF process. We can fertilize the eggs outside of your body and do pre-implantation genetic screening. We can identify the best embryos and put them back, and we've got a 30% success rate. Now, the HFEA says it's 11%, and I'll talk about those numbers a little bit later. We would say with restorative reproduction, well, we can do it for a much lower cost, around $1,750. But what we do is with a restorative approach is we want to understand, why do we think you miscarried? We want to treat your premenstrual syndrome, your fatigue, your anxiety. We want to balance deficient reproductive hormones. We want to improve egg quality and sperm quality. We want, when we restore all of this, we want to allow you to conceive through a loving embrace, and we don't go through multiple follicles, multiple embryos, embryo grading, embryo wastage, and we'll still give you a 30% real live birth rate. And by the way, we have a very low incidence of twins. We're below 2% compared to IVF, even with the move towards single embryo transfer. On a population basis, you're still looking at 10% of IVF pregnancies tend to be twins, and they're more at risk of low birth weight and premature delivery, which we tend to get normal baby birth weight going full term. The difficulty in comparing data is a lot of the IVF clinics don't report on babies' birth weights or weeks of delivery. They just report they don't even report on live births. They tend to report clinical pregnancy, which is an issue I'll talk about later as well. The evidence in favor of restorative reproduction, we have peer-reviewed publications. Our first one from our own practice was using NAPRA technology in 2008 with the Creighton model charts and restorative reproductive techniques. And we found that we got a 52.8% overall live birth rate according to live table analysis in our general infertile population. But this was a difficult population. The average female age was nearly 36. They were over 5 years trying to conceive, and 1/3 of couples had already tried and failed in vitro fertilization. So this is not your typical infertility population, and despite a real challenging population, we were able to get a live birth rate of 52.8%. We also showed for couples that are beyond IVF, where they tried and failed an average of 2 IVF cycles. We published this in 2018, and we showed 1 couple out of 3 would get a live birth with an average female age of 37 and also 5 years trying to conceive, and 2 failed IVF. So these are often situations that are beyond your typical IVF, and we're trying to show even in the most difficult situations, restorative reproduction is worth trying. So how do you compare the two? How can you how can you compare restorative reproductive medicine with in vitro fertilization, because they're so different? In vitro fertilization is 1 single cycle, whereas restorative reproductive medicine is a process over 12 cycles. And quite simply, I would say, well, you got a whole load of couples and they want to get babies. So how hard can it be making a comparison using those guides? And with in vitro fertilization, here's a real challenge, is trying to, when you're looking at a number that's quoted from an IVF clinic, what is that number telling you? The number we really want to know is, per 100 couples who start the process, how many have a baby at the end of the process? And this data, even through the Human Fertilization and Embryology Authority in the UK, it's difficult to get these numbers. And most recent reports aren't even making this data clear and easy for me to see. So this is older data that I was looking at back from 2012. And if you look at the number of couple cycles started, how many live births do you get? The number comes out at about 1 out of every 4 who start a stimulation cycle have a live birth at the end of the process. And that's the number people need to know. If I pay my money and start an IVF process, what is the chance I'm going to have a baby in hand, a live birth? But what the IVF clinics tend to quote are clinical pregnancies per embryo transfer. And what they do is they subtract a sizable number of couples out of the equation who don't get to embryo transfer. And they also include the miscarriages. So those that are pregnant but don't have a live birth are just included as a clinical pregnancy per embryo transfer. And it seems to artificially inflate the success rates when you talk about successful pregnancies, clinical pregnancy per embryo transfer. You subtract nearly 20% of the people who don't even exist in the calculation, so that the numbers are artificially inflated. So that needs to be teased out and emphasized and made clear. A significant number of pregnancies are lost with advancing age. So if those clinical pregnancies, you could argue, oh, most of those are live births. Well, they're not. And the older a woman gets, the more likely those clinical pregnancies. This is from the HFEA data of clinical pregnancies. And then looking at live births, and these are the number of pregnancies that were lost. So 43 plus, 40% of those clinical pregnancies are lost. And this is a good graphic representation of all the cycles started. What are the clinical pregnancies and what are the live births? The clinical pregnancies are the blue bars and the live births are the yellow bars. And you can see how those numbers are very much lower compared to how many started out in the first place. If we just focus on the live birth rate and the way it declines with advancing age, this is the most recent data available of the average live birth rates per 100 couples who start an IVF cycle, how many have a live birth at the end of it. And you can see the numbers are rather sobering, and this is per treatment cycle. So per treatment cycle means it includes the fresh and frozen transfers as a per treatment cycle. When we compare our crude live birth rate with restorative reproduction from the last time we pulled our data together was actually 2015. We are due an update, but when we compare our live birth crude numbers, and this means everybody who came to our practice and was seen twice, 2 medical consultations, because if they come once and they don't come back for a review, we really don't know what happened. They need to come back for a second time to say, yeah, they started that. But if they didn't have a third consultation, they were included in our data as a treatment failure, even if they only came twice. So obviously that's unjustly punishing on our true success rate compared to those who continue as a process over time. But we included that in our data. We referred to those as early quitters, and we still got a very reasonable crude live birth rate, and it's superior to what you would get for in vitro fertilization across all the age groups. On one level, I think this is the fairest comparison, but you could argue, but that's a single round of IVF. compared to a treatment process over time. But yeah, it's a whole load of couples who want a baby. How many had a baby at the end of it? Whether it took one cycle or several cycles, they engaged in the process. And our approach is usually a fraction of the cost of what they would pay for a single IVF cycle. These are the way our numbers worked out. So we had 412 couples who came for 2 or more consultations. 132 of them had live births. 21% had tried and failed in vitro fertilization before coming to us. Our multiple pregnancy rate was under 1%, and our average female age was 37. So it's still a more difficult than average fertility population that we're actually dealing with. There is a statistical correction you can apply called life table analysis, and we got independent researchers to do this for us, and we didn't know how the numbers would come out, but they implemented a internationally recognized statistical correction for those who quit treatment early after 2-3 cycles, instead of continuing for the entire duration. And we can put in a calculation, well, for those who quit early, if they didn't quit early and they persisted and had the same success rate as everybody who stayed in the program, what is our predicted live birth rate for those who would complete treatment in our program? And it's significantly higher. It's kind of like if you take 2 days of antibiotics for a chest infection, how well would it work compared to taking the full course of 5 days? So it's the same idea. It's a sustained treatment over time. And those that would argue, but we have to compare, this has to be repeated IVF cycles to make a fair comparison. The New England Journal in 2009 published a good article of repeated IVF cycles. And this is where funding wasn't an issue. Funding was taken out of the equation, whereby their insurance was going to cover up to 6 IVF cycles. And we looked at the number, well, if you did 3 IVF cycles, and even where the funding was there, emotionally, a lot of people weren't able to keep going. And we're looking at the most optimistic interpretation if they did keep going, using a similar live table analysis that we've done for our own figures. But bear in mind, this for 3 IVF cycles, it's a minimum cost of €15,000. In Ireland, it's probably double that in the United States. And for those who did 3 rounds of IVF, comparing the New England data with our data, it compares very favorably. And we could say that our treatment process over time is broadly comparable to doing 3 rounds of IVF. So it's worth making that point. It's also worth emphasizing there are a number of people we see who aren't suitable for IVF because their egg reserve is really low or because their body mass index is very high, and they're told that they're not suitable for IVF. We can treat those and we can take those on, and they would have been included in our data here. So it's also true there are people that in vitro fertilization can treat that we can't if both fallopian tubes are blocked or you have an extremely severe male factor where the sperm count is persistently less than 1 million. Then we're less confident that we can treat those. So it's worth bearing in mind that there's some variation in the kind of patients we can each take on. Back to those 2 couples that I mentioned at first with our ovarian stimulation strategy. Well, the couple that went for in vitro fertilization and pre-implantation genetic screening, they actually got to the point of grading all of the embryos they had, and they had no embryos left for transfer because none of them made the grade. So they actually disappeared. They were ghosts in the IVF statistics because they weren't an embryo, a clinical pregnancy per embryo transfer. Because they didn't get to embryo transfer, they don't exist on the IVF data, and that's why they can quote a 30% success. But with the 11% success, that's where they exist in the data. They started a stimulation cycle and had no baby at the end of the process. Those that came through treatment, the second couple who actually came through treatment with us, her premenstrual symptom and fatigue and anxiety improved. We boosted and balanced her hormones. We did treatment to improve sperm and egg quality. The couple reported to me that the relationship was stronger. We didn't go through embryo selection or grading, and they conceived with us and currently have a lovely ongoing successful pregnancy. And for them, they had this hopeful optimism. A cycle or 2 passed without fertilization. They knew their health was better. They were enjoying life, and they were allowing this to happen in its own time. They were also very clear. I remind couples, you know what? We can't make anybody pregnant. all we can do is make the conditions favorable and allow that fertilization may come into this pleasant space. And if a cycle passes without success, yeah, it's a little bit disappointing, but we let it go. So, well, maybe next cycle or maybe next cycle. And it's not like the crash out, no embryos to put back. It's all gone and it's devastation, and it's really hard when contrasted with in vitro fertilization. So it never gets old looking at these heartbeats, and this just goes, that's the little head, the heart, the bottom, and the embryo is just about 1 centimeter in size. You get a heartbeat that's racing along very nicely. We can calculate the heart rate, the couple can listen to it, and they can really connect with it early on. Now, this isn't an early screening or anything, so sometimes things do go wrong, but it's uncommon that things will go wrong if we get a really good scan 3 weeks after our positive test. So the next one, that's just a picture of our baby board and a lot of our singleton pregnancies. These were children could see through a program in the last year. On occasion, we do get twins, womb mates like that, but the vast majority of our babies are singleton pregnancies, and ordinarily for us, it's less than 2% for everybody that we're treating. And then when we deal with the couples who go through this process, this is a couple from our website, and they had tried and failed in vitro fertilization twice. And interestingly, she had no symptoms, but she never had a laparoscopy. She had silent, symptom-free, undetected endometriosis. We went to a very good surgeon who discovered the endometriosis, appropriately treated it. Then we implemented restorative medical treatments. She came to us at the age of 38, was told she needed donor eggs. She just had her third baby through our program. So it's just to show with a restorative approach, their health was better. This is on our website at neofertility.ie, where you hear the couples talking about it. We just asked people would they be happy to share their story, and they were quite happy to do that. So it's really all about the couples and trying to help them to realize their dreams. And in many ways, we're like their guide and their coach. And on one level, we step back once we've balanced everything and allow fertilization to come into that pleasant space and hope that it does. And also accept, well, maybe it won't, but if it doesn't, people can move to a level of acceptance over a process of time rather than a crash out if it escapes them. So thank you for listening, and I'm happy to take any questions later on. Bye for now.